So, those of you who did not do well in this exam, this last one, I advise you to start getting together with some kind of a mentor or tutorer, which is Kevin, and I think it will do wonders for you. Like I said, you can hand them out. Like I said to my classes this morning, last year one of my students got 2 years ago, one of my students got a 30-something or 40-something on this exam, and he put it on his wall in his bedroom and he looked at it every day because he said that will be the last time he'll get a score like that. So, that's food for thought. We have plenty of exams this semester. We have a lot of muscle quizzes. We have 3 more lecture exams before we even have the final exam, which is comprehensive. So we got a lot of stuff to do. So if you didn't do well in this one, and remember I said anything under 75 is an F. So if you did not do well on this one, don't stress. This should be a wake-up call for you, and you should do better on the next Thursday.
Okay.
Highest grades in the class were Ashka and Chris. Was it Chris? The other one? Chris Birchler?
Let's go! Let's go!
He was the other one? Chris was at the actual highest. He had 101. So it paid for you to go up there.
Oh, shit.
But you know, he went up there and underneath that little ledge, there was all his crib notes.
Sorry.
I did send you something today, how to draw the brachial plexus.
Yes.
Did you guys all receive it? It is something that you should definitely take note of and learn. Commit this to memory forever, because this, if you use this, you'll never forget about the brachial plexus and what nerves there are associated with it.
Did you grade these? Was it you personally that graded them?
I graded them, and I graded them liberally. Okay? Because there are some things that, like some people wrote the force is greater with the page, when we talked about levers. And I'll talk about that in 1 second. But the force arm wasn't greater when you put your hand above the wrist. The resistance arm was longer for the patient, which required less force for the therapist. So, sometimes I just wrote FA equals, or FA is less than whatever I wrote, I didn't take off for on a lot of you. And sometimes I gave you a point for a 4-point question that I shouldn't even have given you. But I said, you tried, you know.
So I wrote way more than I wanted to. And I accidentally put something.
That's fine.
I contradicted myself in one of the things. With the Valsalva on accident.
Valsalva, yeah.
Because it was in my head. I was like, don't write it down.
And as I said to the group today, also, if you want to hide something from a student, put it in the book. Because every one of these answers is in the book.
Yeah, that's cool. Let's go, boys.
Kyle!
I'll take that.
Sorry. Dude, warm shirts every day.
Every day.
Only.
You didn't like my smiley face with a balloon?
I saw that. I thought it was cute.
Does that work in a soap? God, I almost threw up.
Wait, what?
I think you should earn extra points for actually being able to read the handwriting.
What's the last name of your joint?
Well, you know, if you were the last test in, which I believe, Andrew, when you put your test in, did you put it in the middle or did you put it on top?
Ashka!
You put it on, did you hand it to me? Okay, because usually when I start with the first one, I base everything off of what, like who has the most stuff that's written, and you gave me a lot of good information. Plus, as I start grading these, I get a little tired by the time I reach 15, so I think I get a little bit more liberal, but, I mean, I don't, no, I try to be fair. So if I take off something for one thing, I try to make sure that I look at everybody else's. And I always look to see who gives me the most information, and then we go from there. Like some of you said, there was a vertebral artery question, and you told me this is how you tested, but you didn't say the name of the test, and you didn't say the things that are associated with the test. Because what should the patient experience besides dizziness, the 5 Ds, and I just wrote it down there. Some people I took off a point because there were other things in the answer that I didn't like, but for the most part, I try to be fair. Yes?
For the paper, are we submitting that to Moodle Room
You should submit it into Moodle,
for the lecture, right?
the paper, the history of physical therapy,
Yeah.
into turnitin.com. I mean, Turnitin, it's not turnitin.com, it's Turnitin.
I mean, is there like a link on the Moodle room?
In Moodle, there's a Turnitin section,
Oh,
so turn the paper in there.
Knock off Blackboard.
Oh, yeah. Oh, I'm sorry, thank you. Both Professor D'Onofrio and I forgot to add one thing. I think because we do it more when we do lower extremity, but I think it's important to do now also. So, Benita, if you could come up here. And we talked about heel cord stretch, right? Heel cord stretch was for what? Heel cord stretch is a passive stretch. It's a stretch. It's not passive range of motion, right? And it's to stretch the heel cord or the Achilles tendon, of which the gastrocnemius and the soleus both join to form, to go into the tendon, and the tendon goes into the bone. So here we have a muscle, a tendon, and a bone, right? That's what a tendon does, attaches the muscle to the bone. So one of the way to look for it, lie on your stomach, please, for the integrity, can you lie that way, please? I'm sorry. For the integrity of the Achilles tendon and see if it is intact, can you all see me? Is by doing this. So what does the gastrocnemius, and this is going a little ahead, but the gastrocnemius and the soleus both insert into the Achilles tendon, and they plantar flex the foot, right? So this is plantar flexion of the foot, correct? Or no?
Yes.
Well, you're-
This is plantar flexion of the
Plantar
foot?
flexion, yeah.
Right. Okay, just checking. So this is plantar flexion, this is dorsiflexion. So what should happen if and I'm gonna sit here so you could see, but I would actually be in front of her. What should happen when I squeeze her calf to artificially stimulate the gastrocnemius? Her foot should plantar flex, correct? Does it?
Yeah.
You all see that, right? Okay. This is known as the Thompson's test. Thompson. 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 Thompson's test. And it tests for the integrity of the Achilles tendon to see if the Achilles tendon is intact. Okay? You see this done a lot of times on the football field, on the baseball field. Sometimes they do it in this position, sometimes they do it in a sitting position. Doesn't matter. We're looking for, does the foot plantar flex? This is a better position to do it in. Why? Than a short sitting position.
The short sitting position because that's more soleus. The gastroc ties into the knee.
Well, the knee is flexed here too, so it doesn't
Checks the
matter.
integrity of the Achilles.
Well, there's no range of motion downwards.
Think of gastroc, guys. Think of gastroc.
They don't know that. They don't know gastroc.
Well, it's
They don't
two
know
joint
where these muscles are.
Oh, okay. Forget that. We'll get that later.
Just simple question. Why,
Gravity is involved.
say it again?
Gravity is.
Gravity. Here I have to go against gravity. Is it harder to go against gravity for a muscle than to go with gravity? Yes. So if I'm testing into this position, I'm really seeing if if that foot can plantar flex. So I'm really seeing how strong that muscle is, so it's against gravity. Thank you. Okay? Thompson's test for the integrity of the Achilles tendon to see if we have a rupture of the Achilles tendon.
How would you know, like, if it didn't, Anna? That would
If it didn't move,
If it didn't
then I would know it's not attached, right? The muscle attaches to the tendon attaches to the bone. If it doesn't move, I know it's no longer attached. It's not making that that joint or that foot move.
That's a serious issue.
That's serious, yeah.
Would that, Professor, if there was only a slight tear, would it still happen with?
That's why I would do it against gravity. Because if there's a slight tear, you'll still see it move, but you may see it move in sitting, but you may not see it move, or not slight, I shouldn't say slight. If there was more of a moderate tear, you may not see it move as much, but if it's a slight tear, you'll still see it move. It'll be painful. It'll be painful. It'll be painful when they do it. When you do it, it shouldn't be so painful. Because when you're doing it, it's a passive thing, and you're not asking the muscle to contract and to shorten. You're doing it. Okay? All right, so we talked about this, right? And we talked about what is joint mobilization. We said that the shoulder, and we're going to do this again and again and again, but we just used an example of the shoulder. And we said that the humerus is convex on a concave surface. The reason why I wanted to bring this up is some of you had horrendous answers for this, okay? This concave convex law states there's a stationary bone and there's a movable bone, okay? One stationary, one moves. If the movable bone is convex, you glide it in the opposite direction that the bone is going, okay? Because the bone is rolling one way, and if it keeps rolling and rolling, it's going to fall off, right? So we need to glide it in the opposite direction. So the law states that if the movable bone is convex, you glide it in the opposite direction that you want the movement to go. So if I want the movement to go up into flexion, I glide down into extension. If I want the glenohumeral joint in abduction, now that's a different plane, right? So if I want to increase abduction and my arm is like this, which way would I glide the humerus? Inferiorly or superiorly? That's different from anterior and posterior. It's a different plane, right? So which way do I want it to glide? Inferiorly. And as I glide the humerus inferiorly, the arm will be going up into abduction. Okay? You got it, Corey? Latte? Latte, you have it? Okay. Because I think, yes.
Is it also accurate to say body segment instead of the bone, or no? Should you?
I let a lot go. I let a lot go.
No, I
really.
know.
I just didn't let joint go, because it's definitely not joint. Bone.
Bone.
I would say bone. The other thing I want to tell you about is that you do, and you don't have to know these now, because it's just too difficult, that you're going to mobilize the joint in a loose pack position, not in a closed pack position. The difference between a loose and a closed pack position is the joint can't move when it's in a closed pack position. Ligaments are taut, capsules taut, the bones approximate, they're close together. You cannot mobilize a bone in that position. You have to mobilize it in a loose pack position, where the joint is most freest to move within the capsule itself. Okay? And every joint has a loose pack and a closed pack position. We don't have to learn those now. And another thing, because we didn't go over grades, but they're grades. There's grade 1, grade 2, grade 3, grade 4. Grade 1 is a tiny little oscillation at the beginning of the range of motion. Grade 2 is an oscillation from the beginning to the middle range of motion. Grade 3 is an oscillation from the middle of the range of motion to the end range of motion. And grade 4 is 3/4 of the range of motion to the end. So you know what, I'll draw this. It's here. So here's the full range of motion, let's say, right? Right? Here's a full range of motion. Grade 1 would be this. Grade 2 would be this. Grade 3 would be from the middle to the end, and grade 4 would be from like almost the end to the end. Grade 5 is a manipulation. Grade 5, and I'll show you pictures of this. So this is not going to be on the test next week, okay? It's not. I'll show you pictures and when we start talking about joints individually. But a grade 5 would be a manipulation, where you take the joint to the end range, take a ball of slack and crack it. Okay? We're not doing grade 5. In fact, I could only teach you, according to the New Jersey laws and regs, grade 1 and 2. Okay? Grade 1 and 2 joint mobilizations are for pain. Okay? They're oscillations and mobs for pain. Grade 3 and 4 are for increasing range of motion. Okay? When you get out there and you start practicing, you're going to go on continuing it. You're going to learn all this, get certifications, and be able to do it. Because I truly believe that in order to do full range of motion, you need to know how to do joint mobilization. That's why we have to learn all these joints. Because we have to know which ones to move when we want motion. Okay? Got that? Yes? No? And you can see it's not as easy as you thought it was, right? Especially when we talk about feet. Mobilizing feet and knowing what joints to mobilize. But once you know it, you know it. And does that mean that every therapist remembers how to mobilize a finger because they remember the concave and the convex? No, so what do? They look at the skeleton. So, oh, okay, this one's convex, let me move it. There's no reason why you can't walk out of the room and say, I'll be right back, I gotta check on something. You come back in, you look something up, okay? People do it all the time. Better to be safe than sorry. Okay. So these capsule limitations, and there are capsule limitations for every joint. Every joint provides its own capsule limitation. Capsule limitation will tell you that this is a capsular problem. Okay? And not just a strength problem or a range of motion problem. So it's a restriction that's evident for every joint that makes the therapist think, I have to look at the capsule and see what's going on with the joint capsule. Okay? The capsular mobilization for, right now, what we're going to learn is the shoulder. Okay, because we've been talking about the shoulder. For the glenohumeral joint, the capsular pattern, I should say, I'm sorry. Capsular pattern is ER, just write ER, and then write the symbol greater. Greater, you know the symbol for greater? Yeah. ER, greater, ABD, abduction, greater, IR. What does that mean? That means that the capsular pattern are the limitations that you're going to see most associated with the glenohumeral joint, and know that you have to look at the capsule and mobilize the capsule, is when the patient's external rotation is limited greater than their abduction, which is limited greater than their internal rotation.
So it's more limited then? It's more limited then?
It's limited greater. The external rotation is limited greater than their abduction.
So the greater in there, like, it's more limited?
It's more limited.
Okay, yeah.
Okay, so having said that, Corey, having said that, which is least limited?
External rotation?
Internal rotation, absolutely. Internal rotation. I'll tell you something. Adhesive capsulitis, term used, frozen shoulder. How do people with a frozen shoulder hold their arm? Like this, right? Do they want to do this? Hell no.
Absolutely not.
Do they want to do this? No. They want to do this. So what position are you in? Internal rotation, right? So what muscles are tight? External rotators or internal rotators? Internal rotators. Yes. All right, the light bulb goes off. It's It's nice when something clicks, yes?
So does that mean if you start seeing immobility in external rotation or abduction, that would be indicative of potential capsulitis developing?
Yes,
Okay.
yes. And sometimes you don't see these people until they're full-blown adhesive capsulitis. You know, they've had an impingement, then maybe they had a little bursitis, and a true impingement is, the sign of a true impingement is a painful arc of motion, and anybody that has problems reaching over the head, that's true impingement, at least for shoulder impingement. But they could have a bursitis, they could have a brachial plexopathy, and then all of a sudden you see them 6 weeks later and they have an adhesive capsulitis. Because they're not moving. So, you know, and that's when you see all the scapulothoracic. That's when you see this. This is the
To
ladder.
the fingers up there.
Or this. Oh, I got full range of motion. See, look, I can move my arm all the way up. Oh, yeah, but now I can't hear. Okay, no, it's a joke. My shoulder's in my ear, never mind. Youth is wasted on the young. Okay. So, everybody okay with this?
Yeah,
Yes?
makes sense.
Yes? All right, let's move on. All right. So we're going to talk about the nervous system, and today we'll finish with the brachial plexus. We'll talk about with the nervous system. Don't you guys go to the bathroom before you come in?
Dave,
Damn it, Dave.
idiot.
Capacity is 5 feet.
Okay. So with the nervous system, we're going to talk about, so I don't have to turn around, the autonomic nervous system. What's the autonomic nervous system mean to you? What does it control?
Everything that's non-pulsed.
Things we're not thinking about.
Yeah, mostly the viscera, right? Visceral structures, so mostly the visceral. So peripheral nervous system, cranial nerves, brachial plexus, spinal nerves, lumbosacral plexus, so we'll learn the plexuses. And then the central nervous systems, the brain and the spinal cord. Okay? Brain and the spinal cord. This is just an introduction because you'll be doing neuro next year. But the cranial nervous system, brain and spinal cord, we said, and the peripheral nervous systems, the cranial, spinal nerves, and the autonomic nervous system. The brain and the spinal cord are both covered with meninges, and those meninges are these coverings that support and protect. Does anybody know the name of these meninges? Pad, pia, the arachnoid, and the dura mater, right? So between the pia and the arachnoid are the cerebral spinal fluid. What does cerebral spinal fluid do?
It cushions and nourishes.
Yeah, it maintains, but it cushions and it also maintains your body's electrolytic balance. So the cerebral spinal fluid. So when we talk about lobes of the brain, we're going to talk about in the cerebrum. We're going to talk about the frontal lobe. Did anybody and everybody see, or did anybody see, or anybody not see, One Flew Over the Cuckoo's Nest? You didn't see it?
No, I saw it.
Okay, did everybody see it? Pretty much.
Saw
Jack
psychology
Nicholson.
years ago.
Jack Nicholson, he had a frontal lobotomy, so they cut into the lobe of the frontal in that movie. And what happened? It made him no longer be the person he was. So that frontal lobe is really important in your personality. Okay, it's who you are, your behavior, your emotions. So if somebody has a flat or a flat affect, sometimes we call it a flat affect, they may have problems in their frontal lobe, and you could have an infarct in any lobe, but the frontal lobe, if you see somebody with emotionless, then usually the frontal lobe is involved. See, frontal lobe is also really important for your motor speech. So the ability to say something, the ability to speak. And that is known, in the frontal lobe, there's an area known as Broca's area. Broca, B-R-O-C-A, Broca's area. Broca's areas for motor speech. And if somebody has aphasia is the inability to speak, right?
Yeah.
And they could have expressive aphasia. And that when someone has expressive aphasia, they have something going on with the frontal lobe. Okay? So they're expressively aphasic. So their infarct is in the frontal lobe. All right. Parietal important for sensation. It's also important for, close your eyes. Put your hand, rest, close your eyes. Put your palm up. Keep your eyes closed and tell me what that is. You could feel it. What is it?
That's a pen.
It's a pen. Stereognosis. Stereognosis. Stereo, you know, everyone knows how to spell stereo. Ognosis. That's identifying the size, the shape, and the structure of something. Okay? So that's the parietal lobe. Identification of objects. All right?
I'm sorry,
I think I
closing my eyes
just
and
jumped to
doing
the parietal, huh?
What was
That's
the
all right.
stereo? I was closing my eyes.
Stereognosis.
Identification of objects.
Size,
Yeah, I
shape,
just
and
jumped to the
structure of
parietal.
object.
Yeah. Stereognosis. Temporal lobe, I skipped the temporal. Temporal lobe is important for olfaction smelling, right? Smelling, temporal lobe. So think about those people. Does it ring a bell in any of you? That these people that are having COVID are sometimes losing their sense of smell?
So there's a virus.
So now are we talking about lobes and cranial nerves? Does this not scare you? Because it scares me to think that it's affecting your brain. You better believe it. This is a scary thing. This is not a typical virus.
Well, could it also be like a sinus infection, with all that?
Sinus infection is different. When we talk about the ability to smell at all, because the olfactory nerve is out, that's a cranial nerve. Cranial nerve is in the brain. Okay? So that's a scary thing. That's why I tell you guys, don't bring it here. You know, you're sick, stay home. Stay home. Won't get you thrown out of the program. You need to stay home and quarantine. And you come back when you're better. Okay, so that's what's hearing, language, receptive. Okay? If you have receptive aphasia, remember we said we have expressive aphasia is a problem or an infarct in frontal lobe. Receptive aphasia is a problem with the temporal lobe. And there's an area in the temporal lobe which is known as Wernicke's. Wernicke. Okay? Wernicke's. Okay. So Broca's area in the frontal lobe, Wernicke's area in the temporal lobe. Temporal lobe, if you got problem there and you have a problem with receptive speech, so you're talking to me and you think I know what you're saying, and I'm looking at you and saying, and plus there's other things I could do. Perseveration is something where I repeat the same thing over and over if I'm expressively aphasic. If I'm expressively aphasic, I may perseverate or say the same word over and over, the same letter over and over. And a lot of times you hear people say, because it's easiest, and they think they're talking to you, but they're not, because they don't even know that they're expressively aphasic. So if they're expressively aphasic and receptively aphasic, then they're globally aphasic. Okay? So if they don't have the ability to speak and they don't have the ability to understand what you're saying, that is known as global aphasia. Okay? Yeah.
I suffer from stutter. I'm wondering, is that, not receptive?
Stuttering is interesting. It's interesting. It's not an aphasia.
That's awesome.
But it is interesting because think about when you sing, you don't stutter, right? You don't.
Prove it.
What?
Prove it.
Let me hear you.
You don't build up to know.
It's
I'm not
I know.
a singer, guys.
Yeah, I asked
How
the
much you want to
speech.
hear deep succulent country music?
I asked the speech therapist that one time, and she said she didn't really know, other than the fact that there are different synapses, different connections in that lobe for different areas of speech. You know, speaking rather, and then the musicality is something different. So it's in a different area, so you don't have that those synapses are all working in that lobe where it affects singing, but speech. But you could teach yourself, right, through some kind of a reorganization technique, which they now talk about reorganization of the brain associated with neuroplasticity. So that may be some of the exercises that you have done. Have you done exercises for stuttering?
Yeah, years ago.
Yeah. And did they help?
To a point, yes.
So there was some kind of plasticity going on. Yeah. Which is interesting. It's interesting. And now when you get nervous, because then a different part of your brain is taking over and overriding some of that.
Less nervous, more excited. That's right.
So the brain is very, very interesting.
Which part of the brain would your long-term memory?
What part of the brain is what?
Long-term memory?
Some people say temporal lobe. Some people say parietal and frontal. I've never really gotten great clarification on that. Probably if I talked to a neurologist, he would tell me. But I believe Professor D'Onofrio still teaches temporal lobe. And then you have the middle cerebral artery, which actually goes through the temporal and the parietal lobes as it goes through the central sulcus. And sometimes when you have an infarct there, you have a problem with the parietal, the temporal, and the frontal. So that's when you have global aphasia and memory loss. Okay. Olfaction, Wernicke's. Let's see. Oh, and the occipital lobe. So we have Broca's area, we have Wernicke's area. Broca's area is in the frontal lobe associated with expressive speech. Wernicke's is in the temporal area associated with receptive speech. If they're both out, you get something known as global aphasia. Okay? So, let's see. So what does the... Okay. Okay. So the nervous system, it allows us to maintain contact with the external environment. It provides us with motion via the prefrontal and frontal cortex. And we also have coordination of all movements, and coordination actually occurs in the cerebellum, so coordination and equilibrium. Its capability of excitability as well as conductivity via stimulation. And a neuron is actually a nerve cell and its branches that make up the cell body. So we know what neuron, and they have dendrites and axons. Dendrites go away from a motor nerve. Dendrites go toward a motor nerve, and they're usually multi-segmental. And an axon goes away from a motor nerve. And sensory nerves. Sensory nerves bring information from the periphery to the spine, which eventually reach the brain. And motor nerves come out from the spine, or the gray matter. They have their motor root is in the gray matter, and it comes out through the intervertebral area, and where it travels down the periphery and ends in a motor end plane. So we have a motor nerve. So motor nerves come out, sensory nerve goes in. Sensory nerves brings information from the periphery to the spinal cord, and sometimes through interneurons they travel, and they also travel in white areas known as tracts. And the tracts go up into the brain, different parts of the brain, and depending on what part of the brain they go to, they bring information regarding things like pain and temperature, soft touch, light touch, vibration, etc. Okay? So just to give you an example, there is a tract known as the lateral spinal thalamic tract. And if you think of lateral spinal thalamic tract, it's on the lateral side of the spine. It goes up into the thalamus. So it's named from where it starts and where it goes. And that relays information regarding pain and temperature. Okay? And there's also motor tracts, and there's dorsal columns. Dorsal columns are responsible for things like proprioception. Okay, so knowing where your body is in space. And you'll learn that more next year. All right. The axons are covered with myelin, and this myelin is covered with neurolemma. And that's approximately every half millimeter. There's a break in these nodes. You know, nodes of Ranvier help with conduction. saltatory conduction. So the rate of conduction increases when you have these nodes. And then it also, neurolemma is also responsible for regeneration. There is no neurolemma in the central nervous system, therefore there's no regeneration. Okay, so if I cut a peripheral nerve, I get regeneration, and we'll talk about the fact that there are different cuts associated with these. When I say cut, if somebody were to take an axe and cut through nerve, or cut your arm off, then it's completely severed. So depending on, we haven't talked about a neuropraxia or an axonotmesis or a neurotmesis, but those disorders will render you with the ability to regenerate, and some won't. Okay, so we do get regeneration of peripheral nerves. We do not get regeneration of central nerves, so central nervous system. So that's why if you're quadriplegic or you're paraplegic, at this point in time, you will never get any return. Okay, they're working on things, and there's a lot of scientists that are really talking about the future. But right now, once a spine has been severed, it's severed. Okay, you do not get regeneration. However, brachial plexus, that's peripheral, right? I mean, that's out in the, that's not the central nervous system. So if you have a problem with the brachial plexus, you will get regeneration. The regeneration will take a long time, especially if it's most distal. So you'll get proximal return prior to distal. That'll be last. So your hand will be the last to return in anybody, even like a CVA. We talked about that. We talked about sensory nerves. We talked about tracts, afferent, efferent, which is motor and sensory. And we talked about the fact that it ends in the motor end plate. Okay? So, that's all I want you to know about the nervous system right now. But the cranial nerves are important. And cranial nerves, I mean, there's some people say, and your book says some are mixed. In talking to a lot of the anatomy physiologists and some neurologists out there, they say that 1, 2, and 8 are purely sensory. All the other ones are mixed. So 1, 2, and 8 are purely sensory. So what are 1, 2, and 8? What's the first cranial nerve? Olfactory. And what's that associated with? Smell. Right? So how do you test it? You put something under, you see if the patient can smell. What's the second cranial nerve? Optic nerve, right? No, oculomotor is the third. So an optic nerve is associated with vision. So you could have a problem with, you could have what they call homonymous hemianopsia. You don't have to know this, not now. You will have to know it next year. But you could have an optic nerve problem, which if you have a right optic nerve problem secondary to a CVA and you have an infarct in the occipital lobe, because that's where vision is coming from, then you lose the ability to have peripheral, because these nerves cross, you have a medial and lateral component. The medial side goes to the medial portion of this side, the lateral side goes to the lateral portion of this side, so you have a field cut, okay, secondary to homonymous hemianopsia. But this is far advanced for this class. But I just want you to remember that next year you're going to be talking about this hemianopsia, or this inability to see because you have a field cut. And sometimes that may and may not be associated with a neglect that you have. Left side neglect is much more common than right side neglect. And in a patient that's a CVA, a lot of times they don't even recognize this. You put a bowl of spaghetti in front of them and they'll eat this half. And you say to them, why did you just eat a half? Aren't you hungry? They say, I ate everything, because they completely don't see this. Okay, so you have to recognize this when you go into a patient's room. If they have this left side neglect and they start walking, they don't know this exists, so they'll walk right into a wall with it. So you have to understand that that is because of what is going on inside their brain. Okay, the third cranial nerve is the oculomotor, right? And that's associated with the muscles of the eye and pupillary constriction, so the constriction of the, and also the ability for the eye to go up and down. You know, a neurologist or somebody will say, look at me straight and tell me if you, don't look up here, look at me straight, tell me when you see something. And then they'll say, tell me when you see something. And then they'll say, tell me when you see my finger, tell me when you see my finger. So they're looking for they're looking for to see if the integrity of the oculomotor nerve. Okay. The trochlear nerve as well as the abducens, or the fourth and the sixth cranial nerve, are associated with more circular movements of the eye. Yes?
What's the difference between the optic nerve and the oculomotor then? If they're both vision?
Yes.
What's the difference? Like, what's doing what?
The vision would be-
Where's the line between what the optic nerve is?
Because the optic nerve is purely sensory. The oculomotor is motor.
Oh, okay.
Because they control the musculature that helps you either rotate the eye or look around.
Oh,
Okay?
okay.
All right, so the important nerve for us, there's a lot of important nerves for us, but one of the important nerves for us is the trigeminal, which is the fifth. And that's sensory to the face, and it's also motor to muscles of mastication, right? So if it's sensory to the face, there is something associated with excruciating face pain, and that is known as trigeminal neuralgia. Trigeminal neuralgia. Excruciating face pain. It's also known as tic douloureux. Tic, T-I-C, douloureux, it's a French word for pain. I believe it's D-O-L-O-U-R-E-A-U-X. I believe that's how you spell it. But you could look that up. Ashka will look it up and send it to you. D-O-L-O-U-R-E-A-U-X. Yes.
What is the one for sensory to the face?
Check the other one.
Trigeminal nerve
Tic douloureux.
is, what did I say? Tic douloureux or trigeminal neuralgia. Okay? Excruciating face pain. So cranial nerve 6, I said, is associated with 4. Cranial nerve 7, also an important a nerve for us. Cranial nerve 7, facial nerve. Right? Innervates everything. Innervates our gut to our neck. So sometimes when you work on somebody's neck and you're doing some manual work on their neck, they start to complain that they're going to vomit because the facial nerve has been involved. There's a reflex associated with that. Facial nerve is also very important for us as therapists because the facial nerve innervates all of the muscles of facial expression. So we'll learn all those muscles, right? So I go like this to you, all right, or all these muscles, right? Sometimes I look at you in one eye and say, what? So these are all facial expressions associated with facial nerve. And there is a disorder with facial nerve palsy known as Bell's palsy. Okay, it's transient, it'll come back, but it's a disorder where the facial nerve, where you have temporary paralysis of the face muscles because the facial nerve is involved. Okay, so trigeminal neuralgia, sensory, facial nerve, motor, facial nerve, Bell's palsy, like ring the bell. Then we have the 8th cranial nerve, which is the vestibulocochlear, or it's also known as the acoustic. That's associated with hearing. It's also associated with equilibrium. Okay, balance and equilibrium. The 9th cranial nerve is, I said vagus. Why did I say vagus? I went to 10 already? I don't know why I said vagus. But the 9th cranial nerve is the glossopharyngeal, sensory to taste, the pharynx, muscles of the tongue. Also associated with the gag reflex, your gag reflex. Cranial nerve 10, I said, was the vagus nerve, and I said that's heart, lungs, sensory to heart, lungs, the gastrointestinal tract, sensory and motor. Cranial nerve 11 is important to us. What is cranial nerve 11, gentlemen that were here at the spinal accessory? And what's that associated with? Innervation of?
You're up the trap.
Innervation of the trapezius
Yes.
and the SCM. Innervation of the trapezius and SCM. And then cranial nerve 12, motor to the tongue, hypoglossal. Okay.
Professor, did you say something about cranial nerve 6? Yeah, nuisance.
Cranial nerve 6 works with cranial nerve 4. They work together to do eye movements, specifically circular movements. So one innervates one side to go one way, the other innervates the other to go the other way. More circular movements. Oh, the other thing important is in the brain, we have the cerebrum, the thalamus, the hypothalamus. If you already know what the thalamus, that's your pain relay center, where your hypothalamus is more your hormonal regulation. It's like your inner thermostat, so to speak, like you go out on the wall and when you get cold, you turn up your thermostat at home. When you're cold, the hypothalamus kicks in and turns up the heat in your body, right? The midbrain is where your visual reflexes occur. So if you're, right, Corey? What do you do with a patient? What do you do with a patient when you suspect they may have had an infarct, a stroke? What do you do? When you suspect there's a possible CVA, let's say you find a patient that's unresponsive, and maybe it's not sugar, so they're not in diabetic coma, but you're suspecting that they had an infarct somewhere, and maybe they have a stroke. What do? You're an EMT, right?
Yeah.
The paramedics or the EMTs do it?
That would be
I was an
paramedic.
EMT a long time ago.
Yeah, that would be paramedic. Now,
Paramedics do it now?
Yeah.
So you
If
don't,
we rule out the diabetic.
so you don't shine the light in the eyes?
We do, but at that point, paramedics are
Oh,
on the way.
so shining the light in the eyes is gonna tell you that there's some kind of an infarct in the midbrain,
People dilation.
okay? Because they should constrict. So that's why they do that. And the midbrain is associated with these visual reflexes. Then we have the pons, which is the bridge, and the medulla, which is below. And the medulla is actually a continuation of the spinal cord itself. And in the medulla, we have its control for respiratory rate and heart rate. Right? So if somebody's got a midbrain, or a brain stem, I should say, brain stem involving all these things, a brain stem infarct, what do you think they're going to be on in order to help them breathe?
Respirator.
A respirator. Yeah, they'll be trached and they'll be on a respirator. Okay? Because they can't do it on their own. So that's what you're going to see. Okay, and finally the cerebellum, we said before, was the cerebellum associated with muscle coordination, tone, and posture. So cerebellum problems. If you have a cerebellar problem, it's usually referred to as ataxia. So a patient can be ataxic, A-T-A-X-I-C. I had a patient, years ago was not, a lot of things we said years ago we wouldn't say now, right? Because we've just become much more sensitive into what we say and how we say things, etc. So there is, years ago they used to say if somebody was a heavy-duty alcoholic, there was associated with something known as wet brain. So, and that's not a nice term, but that's what they used to say a long time ago. And I had worked with somebody who was a 42-year-old gentleman who was, his cerebellum was gone, was shot, because he would drink gallons a day of stuff. And he was so ataxic that when he got up, this is ataxia. They can't stay in their base of support, they can't stand. So in order for me, because they try to get him out of the hospital, so in order for me to get him out of the hospital, I had to try to work on stability. How do you do something that there's no carryover in, right? Because there's no carryover. So what I had a gait belt on with weights on the gait belt. I had weights on his feet. I had weights on his shoulder. I had weights on his wrist. Plus, I was doing approximation as I was walking him. That's the only way that he could walk to the elevator. Once he got out, I saw him try to walk down the, but there's nothing you could do. Nothing you could do. But, I worked inner city, and then you see all kinds of, but that's ataxia from cerebellar dysfunction. So just remember, though, somebody could have cerebellar dysfunction because of head trauma or something like that, and show a great debility of ataxia as well as apraxia. Apraxia is more of a motor problem associated with, doing more functional things like buttoning a button. They're not able to do that. And ataxia, there's different types of ataxia. So there's intention tremors, and there's also resting tremors. And the resting tremors are really more associated with something like Parkinson's. So you see somebody doing this when they rest, right? This is actually known as pill rolling, because it looks like you're rolling a pill, as opposed to touch my nose. You say to somebody, I want you to reach for this object, and they do this. So that's an intention tremor associated with more cerebellar problems. I'm getting off on a tangent here, but anyway. We will talk about the blood-brain supply, not today because it's very involved. I just put it up there just to remind myself that we need to do that next time.
So one of my favorite friends is Barry, hates Axel, and she's the one where she could be sitting down, she'll be alright, but as soon as she gets up, she calls it her little dance, because she's just like starts wobbling, and if she's not holding on to something, she'll just fall. And she doesn't really drink, she didn't before, it was just came out of nowhere. Like, she's been going to neurologists and
So it's like cervical myelopathy. But I would do an MRI and look at the brain first. But it could come from the cervical spine. Yeah, it could be a myelopathy. She could have a mass of some sort.
because it's really, really bad.
Yeah, it's not uncommon. Okay? And that's why you rule out things, All right, so we're going to talk about in detail, we'll talk about the vertebral arteries and the vertebral arteries. Right now, all you know is they ascend through the transverse foramen, right? And they go into the foramen magnum, and they join up to form the basal artery, and then they branch off into the posterior cerebral arteries, right? That's all we know so far. That's fine. That's enough. We'll talk about that in detail in a week. All right, I also said that the spinal cord was a continuation of the medulla, and it ends at the level of L2. So anytime they do a spinal tap or something, they do it below the level of L2. Okay? And at the level of L2, it's called the conus medullaris, and at this time, at this area, I should say, we have some nerve or nerve roots hanging down. And they're hanging down in the appearance of a horse's tail. You know how a horse tail hangs down? And that's known as the cauda equina. Okay? Vertebral foramen is where the spinal cord goes in through the spine, through the hard. What's the word I'm looking for?
Transverse bus.
No, through the not through the bodies, but through the skeleton itself, for lack of a better word, the vertebral foramen. But the intervertebral foramen is on the outside of the spine, and that's where the nerve roots exit, via the intervertebral foramen. And we talked about nerve roots, and we said that in the cervical spine we have how many nerve roots? 8 exiting the intervertebral foramen, and C1 exits above the level of C1, C8 exits below the level of C7, right? And then T1 and all the other ones down, further down, inferiorly exit below the level of the vertebra. Okay, spinal nerves, 31 mixed, and we said we have 8 cervical. This is just a review, 12 thoracic, etc. And once outside of the spinal nerve, we have an anterior and posterior root, which joins up to become. They have branches. They have an anterior and a posterior branch, or an anterior and rami is the same word as branch. So we have an anterior and posterior branch. The posterior branch innervate the muscles and the skin of the back, and the anterior rami come around the front, and they form the plexuses. Okay. Spinal cord is approximately 17 inches long. It's a continuation of the medulla, and it goes from the foramen magnum, as we said, to the conus medullaris at the level of L2. And below this level, there are nerve roots that look like this. So the cauda equina. Phylum terminale is this thread-like non-neural filament. These actually are meninges, and they are from below the cauda equina. Okay? So here we have sensory. Remember I said sensory is from the periphery to the spinal cord, and we have motor, which are from the brain into the spinal cord and exit. So if they're going to stay, we have these motor neurons and upper motor neurons and lower motor neurons, which we'll talk about. So the upper motor neurons control what happens in the lower motor neurons. All right. So the lower motor neurons are into the anterior gray horns, and their axons innervate the skeletal muscles. So the axons come out and innervate the skeletal muscles. But the upper motor neurons, the brain and the spinal cord itself, they carry input from the cerebral cortex or the brain down to the lower motor neuron, which eventually projects out into the motor end plate or the periphery and end up in the muscles of the extremities. Okay, so we have an upper and a lower motor neuron. Now, why is it important to know that we have an upper and a motor neuron? Well, I'll skip this for now. Upper and a motor neuron, because there are different findings associated with upper motor neuron. So if I say an upper motor neuron problem is associated with the brain and spinal cord, we could say that a CVA has an upper motor neuron problem, right? Other than somebody with a lower motor neuron or somebody who suffered something like poliomyelitis. That's a lower motor neuron problem. So the signs and symptoms associated with an upper motor neuron. Yeah, question? Okay, upper motor neuron. The muscles become rigid, right? Sometimes we have flaccidity. Sometimes so we can have a CVA that has a flaccid or a spastic upper extremity. But upper motor neuron, we have spasticity associated with that. What's spasticity? Hypertonicity or an increase in tone. Right? So these nerves are firing, and there's no inhibitory nerve telling them to quiet down. Reflexes will be exaggerated. So if I look, so far all you guys know is the patellar reflex, right? Patellar reflex, I believe I said in class, is associated with the level of L4, right? So patellar reflex, if I hit a patellar reflex, determining if I have hyperreflexia, then I know it's an upper motor neuron problem, and if it's already affected L4, then it's probably affecting other things. So I would test other reflexes. Muscle tone hypertonic. We do have muscle wasting. Okay. The clonus is present, and sometimes it's 1 or 2B clonus. A clonus is if I do a stretch to a muscle, then I get an involuntary contraction. So if I quickly stretch a muscle, when I quickly stretch a muscle, what I'm doing is I'm stimulating or I'm getting the muscle spindle to fire, and after I stretch it, it's still firing. So that's known as clonus. You could see it in the upper extremity, you could see it in the lower extremity. You have degeneration present, and most commonly you have a positive Babinski. Positive Babinski is if I stroke the lateral side of the foot and the great toe flexed and the other toes extended. Okay, so that's a positive Babinski. Yes?
I know usually the Babinski sign is tested for like children, but would this be something that would be apparent in somebody who's like an adult?
Yes. Yes, you could see it in children, you could see it in adults too. Yeah, positive Babinski sign. Okay, so that's indicative of upper motor neuron lesion. Okay, so you get flexion of the big toe and extension of the others. What should you get when you do this? You should get a withdrawal. Yeah, you should get, the person should be pulling the foot away. And you should get flexion. So you get flexion of the big toe and fanning of all the others. That's a positive Babinski. Okay. Lower motor neuron person, you see flaccidity, you see hypotonic, you see absent reflexes, and you see a negative Babinski. Okay? So spasticity, disuse atrophy, positive Babinski, hypertonicity, hyperreflexia. And the reason why you have atrophy with that hypermotor neuron lesion is because you have disuse atrophy. as opposed to denervation atrophy. So denervation atrophy, you have, somebody's got a lower neuroinjury.
Can you just define muscle wasting?
Muscle wasting is atrophy, really. All right, we talked about cranial nerves, and the one thing, it says shoulder shrug for accessory, because, why does it say shoulder shrug? We said that the spinal accessory nerve innervates the trapezius, and what did we say that trapezius did? Elevate the scapula. Okay, that's why it says shoulder shrug. Spinal nerves, everyone here, we know this already. We talked about this. We had primary areas. We're going to talk about plexus. Okay, dermatomes. What's a dermatome? Dermatome, area of skin where a sensory fiber of an area of skin innervated by a sensory fiber of a spinal nerve. Right? That's a dermatome. And dermatomes overlap. So it's area of skin innervated by a sensory fiber of a spinal nerve. Why do I need to know this? Because if I'm going to assess where a problem is in a patient, I need to perform an exam. And one of the things, and I will give you a chart, one of the things I do is I take a needle, or not so much a needle anymore, you can't stick anybody, but I take something, I may take a pencil top, and then part of a pencil, or I may take a Q-tip, and then something that's soft, you know, a Q-tip, you guys know what a Q-tip is, and then I don't even have that with me. I have a reflex hammer that I use that has a little roll on it, and it has like little pricks on them, like little pointy things on the roll, and I roll it on the patient. And I said, I tell a patient to close their eyes, and I said, tell me if this is sharp or dull. So I'll use the opposite side of, and a lot of times you see this also in a reflex hammer, the top of it comes off and you have like a feather and you have a pin. And you say, tell me if you feel sharp or dull, okay? And what I'm looking for specifically is these areas of skin refer to specific spinal levels. So if I were to touch you, if it was close enough to you, I would touch you here. And I would say, is this sharp or dull? Keep your eyes closed. And then I would touch you here. 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 And I would touch you here. What I'm looking for is C4 is here. C5 is here. C6 is here. C7 is here. So remember C7. Okay? C7 is here. C8 is here. T1 is here. And T2 is here. Yes?
When testing out dermatomes, do you test out both sides?
Excuse me?
Do you test out both sides?
On both sides?
Yeah.
Yes.
Just compare.
Yes. Yes. You have to make sure that somebody's intact first before you do the other side. So I will give you a chart with this on it, and it'll show you. And there's also a dermatome and a myotome dance, which I'll send you guys, or you could look it up on YouTube right now and learn it. And usually we do one lab against the other, and we see if we give you 2 more points on the next exam. Whoever does it better. So there's a dermatome and a myotome dance. One is to Thriller, Michael Jackson. It's really cool. And once you learn it, you'll never forget your dermatomes and your myotomes, because I'm saying C4, right? C4, C5, C6, C7, C8. So you'll learn it. So those are myotomes. But dermatomes is the area of skin. Myotomes is the muscle that's associated with the specific level. Okay? So C4 would be here, C5 would be here, C6 would be here, C7 would be here. I like doing it. C8 would be here, T1 would be here, and T2 would be here. All right? And I'm going to give you a chart so you'll know from the chart. But you could even actually see it a little bit up there, but I'll give you a better chart. Okay? All right, except for the thoracic nerves, the anterior primary rami of the spinal nerves form these plexuses. And we talked about the fact that we're going to talk about the brachial plexus and the lumbosacral plexus and the cervical plexus, but we're really concentrating today on the brachial plexus. So the cervical plexus is C1 through 4. The brachial plexus is C5 through T1, and the lumbosacral plexus is L1 through L5. Cervical plexus again, innervates the neck muscles. So all the neck muscles are innervated between C1 and C4. Okay. Then we have the brachial plexus, innervates the whole upper extremity, C5 to T1. So we have C5, C6, C7, C8, and T1. Those are the nerve roots associated with the brachial plexus. Lumbosacral plexus, L1 through S5. I said L1 through L5 before, I'm sorry, L1 through S5. There is a lumboplexus and there is a sacral plexus, and sometimes we combine them, and most time we do. Okay, that innervates. Sciatic nerve is coming from L4 through S3. Then the sciatic nerve is the largest nerve we have in the body. And we'll talk about the divisions associated with the sciatic nerve. So, I'm not going to expect you, yes.
Because the sacrum is fused, are there?
Yes,
nerves
they're still
coming out?
nerves, yes.
So there's
Yes,
an-
there's
an
still
actual
intervertebral
fuse.
foramen, yes,
Oh.
yes. So, forget this for now. Forget this for now, for now. I'll talk about this when we talk about muscle. The important thing from this, what do you think? What was the little song I gave you? C3, 4, 5 keeps the diaphragm alive. So no C3, 4, 5 is associated with the diaphragm.
That is
Phrenic
front-
nerve.
front-
Okay, C3, 4, 5, associated with diaphragm. All right, here we go. So, we have the brachial plexus, I said C5 to 12 to T1. We have a superior trunk, we have a middle trunk, we have an inferior trunk. Some people say we have an upper trunk, a middle trunk, and a lower trunk. It does not matter to me how you say it. Okay, as long as you know that we have 3 trunks. In my day, the way you remembered, because we have roots, trunks, divisions, cords, and branches. When I was in school, they used to say that I used the mnemonic. Robert Taylor, see, even I didn't really know him, but he was an actor, an old-time actor. Robert Taylor drinks cold beer. Okay? No, it was Robert Taylor, well, I forget what it was now, because now I use this different mnemonic for you guys. Remember to drink cold beer. Remember to drink cold beer.
I will never forget this.
Okay? Remember to drink cold beer. So what are we dealing with first? Roots, then trunks, then divisions, then cords, then branches. And the branches are the peripheral nerves. Okay? So, there are 3 cords, and they're named for their relation to the axillary artery. There's a lateral cord that's lateral to the axillary artery, a posterior cord that's posterior to the axillary artery, and a medial cord that's medial to the axillary artery. The brachial plexus lies between the clavicle and the first rib. So you could see how easily it can be compressed. And you could also see how easily, if you're not careful with mobilizing the rib or the clavicle, that you could have tingling and numbness in the fingers. Because the peripheral nerves associated with the brachial plexus provide motor and movement and sensation to the whole arm. Okay, so they're motor and sensory.
I'm assuming that's what gets compressed during thoracic outlet syndrome?
Thoracic outlet syndrome is a neurovascular compression.
Oh, okay.
Oh, so we're talking about not only the brachial plexus, but we're also talking about the subclavian artery. Okay. So, C5 and 6 form the superior trunk, C7 forms the middle trunk, and C8 and T1 form the inferior trunk. Posterior divisions of all the trunks form the posterior cord. The anterior division of the middle and the lateral trunk form the lateral cord, and the anterior division of the lower trunk forms the medial cord. This all sounds like gibberish, and it is right now. Lateral cord gives rise to or terminates as a peripheral nerve known as the musculocutaneous nerve. Right now, you know that the musculocutaneous nerve, for those of them, at least in my class, should know that the musculocutaneous nerve innervates what? The biceps, the brachialis, and the coracobrachialis, right? We talked about that a little bit. We will talk about that. It's not going to be on your exam, but we will talk about that more when you guys talk about muscles. We will talk about that. Everybody will be on the same page. I just sometimes throw some extra stuff in. The lateral and medial cord give rise to the median nerve, and the median nerve is what innervates the forearm flexors, for the most part. For the most part. And then the medial cord also gives rise to the ulnar nerve, and the ulnar nerve innervates the medial side of the hand. So the posterior divisions, or the posterior cord, we have two peripheral nerves associated with that, which are the radial nerve and the axillary nerve. And the radial nerve innervates what? Tell me, guys. Radial nerve innervates all of the extensors. Radial nerve innervates all of the extensors. Anytime you see extensor anything, extensor carpi radialis, longus, extensor carpi radialis brevis, extensor digitorum, anytime you see the word extensor as far as a muscle, it's innervated by the radial nerve. Okay? So here it is. But I decided this wasn't a great picture to explain. So I put in another picture. And I will send this to you too. And that's why I also sent you how to draw it. So, but this is what you're going to have to do. Okay? This is the brachial plexus. Do you see C5 and 6 nerve roots form the superior trunk? Do you see 7 form the middle trunk? And do you see C8 and T1 form the inferior trunk? Yes? Do you see the posterior divisions of all the trunks form the posterior cord? Yeah. Posterior divisions of all the trunk form the posterior cord. The anterior division of the middle trunk and upper trunk form the lateral cord. The anterior division of the lower trunk forms the medial cord. You could see that, right? Just what I told you. Joe, you're looking at me like I have
It's
three
there.
heads.
I just can't see.
It's there. But let me tell you, when you draw this, that's why I'm a firm believer of stopping this or stopping just listening. Some people are auditory, that's great. If you're auditory, it works for you. But other people need to write. So you need to take the step-by-step thing that I sent you. It shows you a real easy way. It shows you make an arrow here in a line, make an arrow here in a line, and then make an arrow in the opposite direction in a line, and start plugging in these things. Yes,
Will we have to draw this for an exam?
absolutely,
For our upcoming.
absolutely,
For the upcoming?
absolutely. And the following exam, you will have to know it, because I will say to you, the musculocutaneous nerves comes off the lateral cord, where it initially arises from what nerve roots. So you will have to go backwards and figure this out.
So on the next exam on Tuesday.
On this exam, I just want you to know how to draw it,
Okay.
okay? That's all I want you to know. But I'm going to explain it a little more. So we have the posterior cord, we have the medial cord, we have the lateral cord. Then we have these terminal branches. So the musculocutaneous nerve comes from the lateral cord. The posterior cord gives rise to the axillary nerve and the radial nerve. Axillary nerve innervates the deltoid, the teres minor, and then the radial nerve innervates all the extensors. Musculocutaneous innervates that biceps, that coracobrachialis, and that brachialis, so the upper arm. The lateral cord and medial cord come together and give rise to the median nerve. Median nerve innervates most of the flexors of the wrist, also flexors of the elbow. The ulnar nerve is coming from the medial cord, innervates mostly the flexors on the medial side. Okay? There's also tiny little branches, if you see here, from C5 to T1 nerve root. There's something that's branching off known as the long thoracic nerve. Long thoracic nerve innervates that serratus anterior, right? So that's a big one. So that's really cool when you do cadaver dissection, because if you look at the brachial plexus, it's coming off this root. It's hanging right over the breast. This nerve is sometimes cut during a mastectomy. So if it's cut during a mastectomy, then you lose the ability to protract your scapula. Losing the ability to protract your scapula also affects the upper rotation of the scapula, so you don't have full shoulder range of motion because that nerve has been cut. Okay? And if we look further down, the subscapular nerve is coming off the upper trunk there, and that subscapular nerve innervates the inferens supraspinatus muscle. And then we have the lateral pectoral nerve, which innervates the pecs. And then if we go down to the posterior trunk, we have the upper and lower subscapular nerve, which innervate the teres muscles, and the thoracodorsal nerve, which innervates the lats. And if we come down even a little bit distally to the medial cord, we have the medial pectoral nerve, which innervates the pec minor, and then the medial brachial and medial antebrachial, which are sensory to the medial side of the forearm. Okay? And then there's also, is it missing? No, it's there. Nerve to the subclavius, which is a little muscle that's under the scapula. So, does this look daunting? Yes. It does. Don't say no.
It's easy to follow. It's all right
Okay.
there.
Once you start drawing it, it's easy. It's easy. Okay? But I've given you the picture, and now I'm going to give you step-by-step. Well, I didn't make the step-by-step instructions, but I found the site that did. Yes?
Is there a this may be silly, but is there a reason that the lines going down this way to the divisions, one is solid and one is dashed?
No,
Or is that
that's just to differentiate. And it's also supposed to be like a 3D view. It's posterior, so that's why the lines are dotted. So it's posterior. Yeah.
Sorry,
Is it what?
I
I can't hear.
Is it gonna be on
Yeah,
the
it is.
gonna be an exam next week.
Yes.
I'll send out an update after class.
Gosh, so good. The only thing you have to know for the exam is how to draw it. It's the only thing you have to know. Would it be nice for you to understand it? Absolutely. But, we'll be talking about it more. You can't understand it yet. You really can't. If I send you all the things associated with it and you want to read it, fine. But I don't think it's necessary right now.
1 week from today, multiple choice test.
For next week's test,
Yes.
everything that we did up to today.
It's a multiple choice test.
It's multiple choice, and there's 5, I'm finishing now, 5 fill in the blanks.
So that could be a fill in the blank,
Yeah.
is that,
Okay, so the other thing I want you to know, the mnemonic for remembering the terminal branches or the peripheral nerves associated with the termination of this plexus is MARMU, M-A-R-M-U, MARMU. M stands for musculocutaneous, A stands for axillary, R stands for radial, M stands for median, and U stands for ulnar. Okay? MARMU. So, are we good?
Can you repeat that?
M-A-R-M-U,
no, but,
musculocutaneous,
yeah,
axillary,
yeah.
radial, median, and ulnar. Those are the 5 peripheral nerves that terminate from the cords of the brachial plexus, and they innervate the arm. Okay? All right, I got a question, real quick question. And if you don't know the answer, ask Andrew. Because Andrew and I Andrew's pretty good at this. What was your degree in?
Athletic training.
Athletic training? Yeah. I would think that somebody like you, maybe you would know the answer, because your degree was in kinesiology. So that was pretty good. Raising up on your toes is a specific lever. This is another lever, right? If raising myself up on my toes, and what if I weighed 300 pounds, my body weight would be raising 300 pounds. If you took 300 pounds and put it in my arm, it would be a lot harder to do, right? Why?
Because the second degree lever is for power, so it's more efficient.
Just because.
You're right.
Yeah.
He got it too.
Joe.
Yeah. Yeah. The rest of you, look it up. No, seriously. Because we're talking about 2 different levers. We're talking about a class 2 lever as opposed to a class 3 lever. And that's talking about the resistance arm and the force arm. And some of you guys, and I will say this and then I'll let you go. Some of you guys said, as I said earlier, I don't know if everybody heard me, but you applying resistance more distally when the person raised their arm did not increase a force arm. it increased the patient's resistance arm, which made you use less force to overcome their resistance. Because their force arm still stays the same. Their force arm inserts from the axis to the, so from the axis to the deltoid tuberosity is your FA, right? Your RA is from the axis of the shoulder to your hand. So your resistance arm is much longer, right? Okay. Yes, question? No? All right, so we'll see you guys Monday and Tuesday.